when we start looking at reassessment, it is imperative that you reassess the patient. People have died before, literally died before in the back of an ambulance. Not with me. I lay no claim to this. But with other people because they didn't reassess. Late at night, they're going to the hospital. Maybe it's a long trip. Maybe a 45-minute trip like this one was. People got tired. They got sleepy. They didn't reassess the patient. All of a sudden they get to the hospital. They go to wake the patient up at Children's. And the kid's not breathing. He stopped breathing sometime during the transport. So when they got to the hospital, the kid he'd been in cardiac arrest for some time. The person in the back was doing his paperwork and never reassessed the patient. So they tried, here's cover-up number one, they tried to do this thing when he just went into cardiac arrest. Well, that's a little hard to believe since he has lividity, okay? And that didn't go very far. They were just grasping at straws on what to do. And this kid stopped breathing sometime during the transport, and they didn't reassess the patient. So, very important to continue to always reassess, just not for life-threatening emergencies, okay, but on just general good patient care. Is your treatment doing any good? So we'll talk about these stable and unstable patient. So reassessment is just that. It's just a continuous on-looking of the initial things that you've already done. You've already done the ABCs. You've already done the focused exam, the physical exam. Reassessment is just going back over the majority of that. And here, looking for these trends and changes. Very important. EMS, medicine, nursing, whatever medicine you're going into, always looking for trends. Okay? When you start looking for trends, you find an enormous amount of things. And then just changes in the patient care. So, they can either be subtle or profound, big changes or little changes. The little changes will eventually add up to big changes if we don't correct them. So that's why we want to look for the little things. Any sort of improvement is what we want, right? And when we look at improvement of what's wrong with the patient, that's the goal. We're always shooting towards, improving the patient's condition. So if they're in pain, we want to relieve that pain. All right? If they're having trouble breathing, we want to help relieve that shortness of breath or that difficulty breathing. All right? So these are the things that we sort of look at and to identify, and we always look at improving patient condition. Constantly check for life-threatening events. Okay? What's going to happen here is that you're going to get caught short, and someone's going to die because you're not reassessing. Patients don't stop breathing. They're not going to cardiac arrest. They don't get worse. You're not doing to identify that. And 1 minute they're with you, the other minute they're not. And it's a weird deal when someone dies right in front of you. So make sure that you're continuously looking for this. Mental status is a big thing. As we work through these medical emergencies, we'll get more into what causes an altered mental status. Always make sure that you're doing the ABCs. Make sure that the respiratory rate's still normal, the heart rate's normal, or at least it's the same as when you picked them up. If you can't fix it, right? That their skin's warm, pink, and dry. If it was warm, pink, and dry when you picked them up, make sure it's warm, pink, and dry during your assessment. So these are the things that you will start looking at. When you reestablish patient priorities, this is when we get into triage. A little bit later, that'll make more sense there. compare, you always have a baseline. So you have that baseline of what was the first vital signs, what was their first, pain. Was it a 6? Now it's a 10. We have a problem, right? The patient's in more pain. Am I giving them enough oxygen? Are they using the oxygen that we're giving them? Did I start them out on a nasal cannula, and all of a sudden now they're breathing through their mouth, so I have to switch that to a mask, because now they're a mouth breather instead of that, breathing through their nose. And always, documentation is next class, but we will look at documenting. If you guys start to work in pre-hospital medicine, or you go to work in the ER, wherever you don't work at, your documentation is very important. Say you don't work till you get out of school and you become a nurse, right? Documentation. You still have to document the way that we're talking about here in the next few days. The documentation is what's going to keep you out of trouble. Poor documentation gets people into a lot of trouble. Potentially lose their license. So whatever their chief complaint is, that may change. So all of a sudden now their additional chief complaint might be chest pain, and all of a sudden now they're having short of breath, or they're dizzy, or they're nauseated. So this may or may not correlate with their chief complaint. So it may start, their complaints may start to change. Signs and symptoms may change. Hopefully they're getting better. When you repeat the physical exam, you don't necessarily have to go again from head to toe and repeat that whole process. You can see they've been with you the whole time, so you know that nothing has changed, unless one of their eyes popped out or something, right? You know nothing has changed on the physical exam, but you need to reassess. Primarily, let's say they're having abdominal pain, and you assess their abdomen, and it's tender to palpation. So when you go back down, you focus in on that. Check see if that abdomen is still tender to palpation, or maybe their anterior chest wall is tender. Is that still tender? All right, so re-examine what you find on the baseline. And then you may have to, like we talked about with the oxygen, you may have to do an intervention, something different. You guys are going to learn about pharmacology here, a couple class periods, so you may start having to give some drugs. Who knows? Always check ABCs, make sure that they're breathing, make sure the oxygen that you're giving them is adequate, that it's doing what it's supposed to. They may be on a non-rebreather like this patient here, and then you may have to switch and start bagging the patient. And so, or you might need to start giving them a breathing treatment. And you definitely wouldn't want them to be bleeding and not notice that. I had a partner I worked with the other day. He started an IV on somebody. He didn't successfully get the IV. So what he did was he pulled the IV catheter out and put a little pressure on it, but he didn't pay attention. He didn't put enough pressure. He goes, "Oh, I can't get the IV," and I was doing something else behind the patient. I go, "Okay, I'll get it en route, no big deal." But he left the patient bleeding on the ambulance floor. His hand was down there by the floor. The patient was just bleeding out where he'd stuck in with that IV. He didn't take care to wrap the IV up, the puncture, the vena puncture up, where he took the needle out. So the guy was just bleeding all over the floor. And so those are type things. An IV could get pulled out or something, and then all of a sudden the patient starts bleeding through it. So these are things that you sort of have to watch for. And this guy lost a significant amount of blood between the time that I looked up and I looked over at the floor going, "Oh, where's all that blood coming from?" So it could be a little different. These are the things you have to watch for. Always look for these trends, repeat, and then it's a skill that you may or may not have, but you need to start getting used to it and start looking at these trends and seeing how all these put together, you know, and then evaluate the trends then do that according to your patient care. So you look for patterns. When you start trending, you start looking for patterns. The patient, they will give out certain patterns. So you look for that trending pattern as when you start observing the trends. Mainly right now, it's just with the vital signs. You start trending the vital signs. And later on, once we get more into patient assessment and we practice more patient assessment, you'll see other trends that patients do. You know, the trend for someone having a heart attack is nausea and vomiting. That's one of the signs that go along with that. So you sort of look at that and you're thinking, okay, this person's probably having a heart attack. They're not nauseated yet. They probably will be, because we know from patients in the past that all those patients in the past with having MIs, they got nauseated and they started throwing up. So something similar to that. So we reassess stable patients every 5 minutes. We'll get a better definition of that. You know, what's stable, what's unstable. Unstable patients every 5 minutes. So pretty much a stable patient is someone that's alert and oriented. They don't have any respiratory problems. They're not having any cardiac-related chest pain. No altered mental status. These type of things. Those patients are stable. Unstable patients are patients with low vital signs, altered mental status. If their chief complaint is stroke-like symptoms, if they're having dizziness or headaches, unexplained headaches, sign of a stroke, heart attack patients, those are patients that you want to reassess every 5 minutes and then start trending their vital signs and their condition appropriately. If you have an unstable patient, most EMS agencies, when they do QA and QI, when that guy looks over your chart to make sure that you're doing it right, if they see an unstable patient and it doesn't correlate with vital signs every 5 minutes, you're essentially in violation of the standard of care. So if you ever had to go to court over a case and it was an unstable patient and you didn't have vital signs every 5 minutes, you've lost. You might as well write the check because you violated the standard of care. Because everybody knows that unstable patient, you should reevaluate every 5 minutes. If you didn't know that that patient was unstable, then you really lost. Because that's your responsibility to make sure that you know. And as we get through the medical part, you'll see that. You'll see what we would classify as stable and unstable. So compare the two. You have a stable medical patient. Just make sure you always repeat your primary assessment. That's easy. You talk to your patient, right? You check a radial pulse every once in a while. You repeat those. Repeat your vital signs. Look at the vital signs. As we will learn in shock, that your blood pressure is not a good indicator of shock. It's the last indicator. So you look at the rate. This is why you want to start looking at your vital signs. If all of a sudden the patient's heart rate starts to climb and you've been trending it the way that you should, and the patient's heart rate starting to climb, that's a problem. You need to stop and identify what's making this patient's heart rate go up and document that. So, and also what you've done, so let's say you've given the patient oxygen, you're giving them nitro, you're rechecking the vital signs, okay? So you've got to always sort of go back over your work It's a continuous deal. You pick up the patient, you do an assessment, then reassessment. Then you wait, then you reassess.
What happens if like they're not stable, like they're not breathing, so someone has to breathe for them, and like they have an uncontrollable bleed? Like, how do you reassess every 5 minutes if you're trying to, if both people are busy doing something? When do you find time to reassess?
Multitask.
Okay.
Yeah. I mean, that's not really an answer to your question, but you've got to find time. I mean, probably a better answer to your question would be that over a period of time you get faster at reassessing. But it is a good question because you take care of the life-threatening problems first. So if they're not breathing, always breathe for them. That's always good. Okay? And then an uncontrolled bleed would be C, so you have to take care of, you're still taking care of your ABCs. Now, maybe this is what you're talking about. You may never get to your head-to-toe exam. You just may never get there. I've taken care of patients who I've never got past A. I spent the whole time trying to get an airway. So the head-to-toe exam didn't happen. So I just had to document, complicated airway, blah, 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 right? And physical exam wasn't completed. There's nothing wrong with that, and it's not against any standard of care because you're taking care of the ABCs. So if you're tied up in there somewhere and you don't check distal pulses, or you don't, you're listening to lung sounds because you're breathing for them, but you don't palpate the abdomen, you don't do any of that stuff, oh well, because that's not essential at the time. That happens quite a bit. Unstable patient, again, sort of the same thing. You'd repeat the vital signs, 5 minutes, repeat the trauma assessment, check to see if your interventions are doing any good. If not, can you change those interventions to do better? So it's not it's just sort of this continuous cycle the whole time that you're with the patient. The last thing that you want to do with the patient is essentially do nothing. You always want to be sort of talking to the patient, asking them if, are you breathing easier now? Or is your pain gone away? If it's the heart rate issue like we talked about, you can't figure out why they have this increased heart rate. Do they have anxiety? Is it just an anxiety issue? So all that you're sort of calculating, documenting, and reassessing. All right, questions on just the reassessment? The main thing is 5 minutes for unstable patient, 15 minutes for stable, and then just a continuous reassessing as you go through.